This is the third session in Understanding Composites, information designed to help you be a better clinician and advance your career. Today's subject is CMT, or Charcot-Marie tooth. It is a motor and sensory neuropathy that is the result of a genetic defect. It is the most common inherited neuropathic disorder, at least in the U.S., affecting about 1 in 2,500 people in the U.S. It is not fatal. Most people have a normal life expectancy with CMT. So you will be seeing these patients when they are diagnosed with the disease, and you'll probably be seeing them for a long time. This disease was named after these three doctors, Dr. Charcot, Dr. Marie, and Dr. Tooth. Apparently in the 1800s it was a wise thing to have a disease named after you. But it is a genetic disease, but it affects two parts of the nerve. It affects the axon, and it also affects the myelin sheath. The axon, if you were to equate it to an electrical cable, the axon is the copper wire, which would be right in here at the middle of the nerve. The myelin sheath would be the covering of the copper wire, or the insulation of the copper wire. But both of these genetic problems affect the velocity at which the nerve can conduct impulses. And when the nerve cannot conduct impulses at the right speed, there's a number of things that happen. First of all, what happens is that there's a decrease in muscle function as a result of that, and there's also a decrease in sensation. So it's this double-barreled problem that CMT patients always deal with: a lack of sensation and proprioceptive feedback, and a lack of muscle control over some of the muscles in their lower extremity. There are many types of CMT. The two major ones that you will probably run into are CMT1 and CMT2. If you look at the stats here, CMT1 comprises about 30% of all CMT patients, and CMT2 is somewhere between 20 and 40%. So if you add those two together, you get something between 50 and 70% of the patients you see will be either one of these two types of CMT. Although there are certainly many, many other types of CMT. Even within CMT1 and CMT2 categories, there are subdivisions of the disease, like CMT1A, CMT1B, CMT1C, and all of those get their names depending upon what gene has been the cause of the problem. CMT1 is a demyelinating disease, which means it affects the covering of the nerve. CMT2 is an axonal type disease, which affects the internal wiring of the nerve. Both of them reduce velocity at which the nerve impulses travel, and as a result of that you get some deformities that you see here at the bottom of the screen. And the most common deformities that occur in CMT is this cavus arch right here. There also has some hammer toes, and as a result of that you have a very decreased amount of surface area that actually touches the floor in CMT patients. So what normally touches the floor in the foot of the CMT patient is the calcaneus, the first metatarsal head, and the fifth metatarsal head. If they have a lot of varus deformity in their ankle, even the first metatarsal head may not actually be touching the floor that much. So it just would be the heel and the fifth metatarsal head. In the hands, you can see here that the thenar and hypothenar muscles of the hands are pretty depressed, and the intrinsic muscles of the hand also are not functioning well. This may only come into play if your patient uses a walking aid of some kind, like a cane or a walker, and they may not be able to grab a hold of it the way that everyone else can. So the clinical symptoms for CMT are a long list here, and there's lower extremity weakness. There's this high arch, which means there's a reduced amount of surface area contacting the floor with regard to the feet. There are hammer toes, there's drop foot, varus ankle deformities. We'll take a look at that closer. as we go along here today. A loss of sensation or proprioceptive feedback. So many times CMT patients have trouble even standing still, trying to make sure that their center of gravity is located over the base of support. There's a loss of muscle bulk due to decreased velocity of the nerve conduction, so the muscles atrophy. There's a steppage gait, high frequency of tripping and falling, and obviously a decreased ability to run. So here are some examples of CMT patients. The first thing you want to notice is that there's a decrease in muscle bulk in the lower extremities. The calf musculature is fairly atrophied. The next thing you want to notice is that there's a significant varus deformity. He actually is bearing weight on his calcaneus, and his fifth metatarsal head, his first metatarsal head really doesn't contact the floor until the end of second rocker, which is toe off there. The last thing you want to look at is to see just how unstable he is when it comes to walking. He's constantly shifting his feet around on the floor in order to maintain stability. So there's a proprioceptive problem as well as a muscle problem. This video on the left, it's rolling now, is just showing you the first day that he got his new braces. These are medial struts. One is an anterior shell, the other one is just a standard calf band. But as you can see, his foot is pretty flat on the floor, and he has a little bit of a heel-toe gait now, instead of just plopping his foot on the floor right to second rocker. This video on the right is him 2 weeks later, and you can see after he's gotten used to wearing the braces, he's much more controlled. It's a much more controlled gait. His center of gravity is well balanced over his feet. He has a very good heel-toe gait. And if you didn't know this guy, you'd probably think he was just a normal individual without looking at his braces. This practitioner also put a heel lift on the left side, which has also helped his balance a little bit. But you can see that he has a much improved gait. And again, these braces only weigh 6 and 7 ounces. Here's another example of a CMT patient. Again, notice the reduced musculature in the lower extremities. He has a fairly significant foot drop. His foot is actually slapping the floor there. And of course, he has to hold on to the parallel bars because without any braces at all, he's pretty unstable. He just has trouble maintaining stability as he walks without any AFOs. And here he is with his braces. Of course, you notice right away that he doesn't have the foot drop anymore. He has an established first rocker and a controlled plantar flexion between first rocker and second rocker. He's much more stable. He can stand independently without holding onto the parallel bars, and he doesn't even need to hold onto the parallel bars when he walks. And all of these braces will fit into the normal shoes that patients walk into your office with. So we've developed some of these clinical guides that are helpful for you in order to select the right AFO for your CMT patients. If you need a medial strut, they would always be medial struts, but if you need knee stability at the end of terminal stance, you would want to use an anterior shell model. And what that provides is at the end of second rocker, it provides pressure to the front of the knee, stabilizing the knee if there's a problem with knee buckling at terminal stance. If you need recurvatum control, we recommend the posterior strut model right here. And what this does is it provides recurvatum control between the first and second rockers of gait. If you don't need any of those, we recommend this one here at the bottom. This is a medial strut with a T-top. You get a little bit of anterior and posterior control, but it really doesn't affect the knee that much. But this 3-point pressure system is important to keep in mind with CMT patients, especially with the varus ankle. We want the medial side, we want a proximal force and a distal force. And the third point right here has to do with the strap that you use on the lateral side. We have three ways of controlling varus ankles. The first level has to do with just using a wedge on the lateral side. And what that does is it pitches the foot toward the medial side. And many times for mild varus problems, that's all you need. If you need more than that, you want to add a supramalleolar strap. So you would use the wedge and the supramalleolar strap as the second level of control. If you need much more control than that, then we use a SMO, a lateral half SMO. You don't need the medial half of the SMO, it just kind of adds bulk to the shoe, but you can use a lateral half SMO. These can also be wedged because there's foam on the bottom of the SMO as well before it's glued onto the footbed of the carbon brace. So these are the three models we recommend for CMT patients. These models only weigh about 7 ounces, and they certainly provide increased stability and increased function for your CMT patients. In summary, CMT is a hereditary peripheral nerve disorder. It involves both motor and sensory nerves. That's important to remember. And we're trying to prevent foot drop, stabilize the ankle, especially when they have various problems with the ankle. We want to increase ground contact with a custom footbed. We want to provide mid-stance stability, helping proprioceptive feedback. We want it to be flexible enough so that it doesn't interrupt the rockers of gait. That's important with these people because they have decreased muscle function as well. And we also want to provide an AFO that fits into their shoes. As you can see, both of the examples that we saw earlier, they're able to use the same shoes that they would wear, even if they didn't have braces. So thanks for joining us today. I hope you learned a little bit about CMT patients. It's information designed to make you a better clinician and to advance your career.